Good evening, everyone. I see we have some participants already in. Thank you for joining us tonight. We will begin in a few minutes on the hour, the webinar. So please bear with us. We'll be back in a minute or so. Good evening, everyone. Thank you for joining us tonight, this afternoon, for some of you out west in Canada. Tonight, we're very excited to be presenting you a new webinar about implantology. Now, tonight the topic is going to be about the mechanics of success for implant cases. And we have the honor of getting the webinar presenting by Dr. Omar Younis. Dr. Younis has been based in BC for several years. He is a dentist and is also a user of Dienobite, which is a bite force measuring device we'll be covering tonight. He's also the founder of a digital implant treatment planning company called DGRX. So we have the chance to have him talk to us about pearls about implants and best practices. And really, we're going to also cover a little bit about what is bite force. Tonight, we're happy to be hosting the webinar. So each and every one of you will be receiving an email following the completion of the webinar with your CE certificate in it. We would love to have your questions during the webinar. So please, if you have any, you can type them in the chat section of the webinar. You can find the button on the bottom of your screen if you click on chat. There's going to be two Q&A segments during the presentation where we're going to be answering the questions live. So please feel free to write them. Now, without further ado, I'm happy to be passing over the microphone to Dr. Younis. And Dr. Younis, please, you can start your presentation.
Thanks, Fred. Thank you very much. And good evening, everyone. I know it's pretty much the end of the day for everyone on the call. Some people are probably past the time for dinner already. So I will try to make this as enjoyable and as fast and as much as I can. Thank you very much for joining today. And I'll be happy to spend the next 45 minutes with you. A quick intro about myself. My name is Omar. Thank you, Fred, for the quick introduction. And I'm a dentist by education. I graduated in 2006, back in the days, in Alexandria University. I live in Vancouver, Canada, which is the beautiful city of Vancouver, which is becoming even more beautiful with the autumns kicking in. And I graduated from a very similar city when it comes to the weather and the landscape, which is Alexandria, back in Egypt. For you who are pretty much interested in history, this is another coastal city by the Mediterranean Sea, and it's a cosmopolitan city. During the World War II, there were actually many more Greek people and Italian people than you can find in many of the Italian and Greek cities. I have only one daughter. She's the sunshine of my life, and she looks pretty much and speaks and behaves pretty much like myself. I'm not sure if that's going to be good for her future or not. And I have the whole list of my career in connecting the dental industry, the advanced dental technologies, with the clinical space. I had the privilege to be a trainer for BioLaser dentistry in the World Clinical Laser Institute, to be a member of the International Congress of Oral Implantology, and to be a member of the training teams of multiple dental companies, multiple leading dental companies, including Nobel Biocare, XNAP, Dexis, 3Shape, and many others. Currently, I'm holding the position of the clinical director of DGRX, which is a company based in Canada and serving North America, providing digital treatment solutions for GPs, for implant placing GPs and implantologists, allowing people to use AI-assisted web-based software to design their cases or to send their cases for our experts to plan for them, or to actually use our platform for referral, to manage their referral to and from the oral surgeon. And for your convenience, I will start this presentation with the very, very final conclusion of it. Based on the collective research, which we will going to be referencing some of them in this presentation, based on numerous amount of research, we can simply conclude that the patient individual bite force measurement should be highly considered as an essential baseline diagnostic and risk assessment information in everyday dental practice. However, before we jump into that conclusion, we may want to go back a little bit, a couple of steps to the very fundamental question on how do we judge, how do we evaluate the success of any dental treatment. And here I'm talking not only implantology, we will have a focus on implantology in this particular presentation, but in the great scheme of things, in the large scheme of things, how do we judge the success of dental treatment? I would say the very principle and the very old way of judging the success of dental treatment is based on functionality. So once we have a dental treatment, this is one of the early reasons people used to go to the dentist. They lost the function and they want to restore this function back. Then the aesthetics, which is one of the biggest reasons people still go to dentists nowadays, is to restore functionality and aesthetics. However, we can have a great functionally and aesthetically accepted dental treatment, but if it's not living long enough, if it doesn't have the longevity, then it will still be considered failure, at least from the perspective of the patient. And one interesting thing here, that any dentist is probably able to judge and to evaluate the functionality of the treatment momentarily. Like you can immediately judge that, the patient can feel it, you can judge it, you can have that evaluation immediately. And the aesthetics too, like if the patient is happy with the aesthetics, that's also another parameter of success that you can momentarily judge. However, when it comes to the longevity, this is pretty much comes to your ability to predict how long this is going to be living in the mouth of your patient. And in reality, there is no way to judge or to evaluate or to predict the longevity of any dental treatment. The only way available for that is to decrease risk. If you think of any clinical protocol that you follow, like in implantology, when you go for this sequential drilling, the angulation of the implant, the angulation of the abutment, when you think of endodontics, the way we do endodontics, the sequential treatment steps that we usually use, these are all aiming to one single thing, which is going to be decreasing the risk factor in order to increase the possibility and the longevity of any dental treatment. And when we are talking about risk factors, it's very simple to summarize the risk factors within the dental environment, within the intraoral environment, within the three main risk factors: the biological factor, the chemical factor, and the mechanical factor. These are the three main reasons. And it's not very surprising when you look at different articles and different researchers that have concluded that pretty much the mechanical factor is one of the greatest factors of success, and at the same time, it's one of the greatest factors of failure when it comes to the success and failure and long-term success of prosthetics or of dental treatments in general. So in the dentistry journal in 2024, you can see that coding from Patel et al. That it was a retrospective chart review quantifying the reasons for failure in direct restorations, composites, and amalgam, and it provided very much equally distributed percentage breakdown between the three main big failure and success factors, including the secondary cares, which is the biological factor, the fracture, which is the mechanical factor, that's a 25%, and all other factors combined are 38%. If we want to focus particularly in implantology, we can look at this nice article that was published in 2023 by Dees et al. About the overall prevalence of mechanical complications in implantology. And the mechanical complications in implantology is actually double the biological complications of implantology. So I would say when we look at the success rate in implantology and in each and every other dental treatment, the mechanical factor is definitely one of the factors that needs to be heavily and carefully considered during the treatment planning. However, we usually, if you attend any course about implantology, we usually see people talking about biomechanical factors, implant biomechanics, but at many times we don't have any way to quantify that. We don't have any way to measure that. Before 2015, the dental industry didn't really see any tool that can measure bilaterally the overall patient bite force for each and every individual patient. In 2015, Fred and his team introduced this very nice tool. As far as I understand, this is the one and the only tool in the industry that allows the doctor chairside to be able to measure immediately the patient bite force using this nice mouthpiece, and you put it in the patient mouth. You ask the patient to bite as heavy as they can to exert the maximum bite pressure on that. And the device is going to show you the value in Newton. And we can always, when we are talking about what bite force is, we can always jump to these very basic definition. What is bite force? It's the total force that's going to be generated by the masticatory muscles, transmitted through the teeth and implants to the opposing arch. We can simply conclude that in one sentence, which is the net load that's going to be applied on a contact point or a surface, and it's by definition is going to be measured by Newton. However, there is from my perspective, I think it's even more important to understand what bite force is not, rather than understanding just that definition of a bite force and what bite force is. But I would say it's very important to understand what bite force is not. One of the very famous misconceptions that we will be going to dismantle here: bite force is not bruxism. That's very important to understand. Bruxism or any other kind of baro-oral habit is not bite force. If a patient has a normal bite force, a deficient bite force, or an excessive bite force, this is not necessarily related to any baro-oral habit. So some patients, they have excessive bite force and they are not bruxers. They have no baro-oral habits. Some other patients, they have very light bite force, even deficient bite force, but they have bruxism. I would say combining both together is increasing the risk dramatically. So assuming that there is a patient who has a baseline excessive bite force, and at the same time, this patient is also suffering from bruxism, clinching, or any kind of other para-oral habit, that means that this patient is going to be in an extreme risk. The other thing is bite force is not the occlusal mapping. So I'm 100% sure that most of you may have seen these occlusal mapping devices, which can be referred to as digital articulating papers. They are also available in the embedded softwares in most of the intraoral scanners available now. And this is basically a kind of an occlusal adjustment tool. However, this nice occlusal adjustment tool cannot quantify or measure the total bite force, the total net load that this patient is able to exert on whatever treatment that you are going to put in this patient mouth. So that's usually a source of confusion, because many people would think, okay, the areas that are marked in red, these are where the heavy bite force is going to happen. This is going to have excessive bite force, which is not true. This is an area of heavy bite contact, which means there is going to be some sort of a load concentration in this area. However, that's not related to the overall bite force that the patient is able to exert. And again, combining both factors is going to tell you how far is the risk for this patient and for this treatment to succeed or to fail. One other thing which bite force is not, it's definitely not the value that you receive from any manual catalog or any of the sales reps out there. So when a sales rep comes to you and talks to you about their composite and says, this composite is 300 megapascal, the compressive strength of 300 megapascal, the porcelain is 400 megapascal in average, and the zirconia is 1000 megapascal in average. This is not connected to the bite force, because the bite force is way more dynamic, and it's not related to the material. It's basically related to the ability of the patient muscle, to the functionality of the patient muscle. And in reality, this is how they measure the compressive strength. It's being measured in the lab. It's by applying the equation of applied force divided by the surface area. However, in real life, this is how the patient applies bite force. It's way more complicated, and it's directly proportional to many other factors, including the muscle structure of the patient and the and the anatomy of their jaws, and the location of the point that this patient is going to be biting on. Diving into these details, now you are able probably to look in more clarity to this definition that we mentioned before. So the bite force, it's not the megapascal value of compressive strength. It's not the occlusal balance that you can see by occlusal mapping devices, and it's not the paraoral habit. The bite force is the net load that can be applied by any patient at any contact point, and it's usually going to be measured in newtons. So maybe the question that brings itself to the table here is going to be, okay, that's nice. Now we know that the bite force is the net load, but how can we measure it, and what can be considered normal? What does normal bite force look like? Based on hundreds of thousands of measurements that has been done, and statistically, we could simply put that spectrum of bite force, anything between 400 or maybe less than 400 and 650 newtons, that's going to be kind of very light bite force. We can consider it deficient bite force. For patients who have bite force between 650 and 950, those are going to be considered the normal range patients, 650 to 950 newtons. And anything above 950 newtons or 1000 newtons, these are the patients that can be considered on excessive bite force. And obviously, you can see patients on both sides of the spectrum. So you can see patients like this patient, for example, with 1128 newtons, which usually those patients are highly susceptible for future vertical dimension loss, highly susceptible for future failures, mechanical failures of different treatments, of different prosthetics or restorations that are being placed. And usually those patients, even if they don't have any sign of bioral habits, bruxism, clinching, or any other kind of bioral habits, they are usually highly recommended for prophylactic night guards, and they are usually highly recommended to be when it comes to the material selection, to use the maximum strength material that can be used in restoratives and in prosthetics. Some other patients, they will be on the total opposite side of the spectrum. And you can see some patients really when they have multiple edentulous areas around the upper arch and the lower arch, you can see them you can see the bite force dramatically affected, and it's going to be even less than 100 newtons. One of the nice things, now we can always relate that to the daily life of our patients, which is one important thing for patient communication. So usually a normal human will need around 150 newtons to eat any kind of edible bakeries, like the regular bakeries. The carrots, which was a little bit of a surprise for me at the beginning, for eating carrots or cucumber, you need pretty much like 450 newtons, which is quite a lot. And in order to start eating steaks and any other kind of chewable meat, that's going to be kind of, you need pretty much around 700 newtons or a little bit more. And I would say that's one nice thing to quantify that when we are talking to the patient, because if you measure the bite force of the patient, then now you can basically locate the patient where they are on the spectrum, and based on that, you can advise them which kind of restoration, which kind of prosthesis. And the question that may come to your mind at this point of time is going to be how many people would be falling in normal, and how many people may be falling in the deficient or the excessive or the high. The answer was very, very surprising for myself, and I have tested that multiple times in many areas of the world. I would say probably in 3, 4 different continents that I have traveled to lecture to. And believe it or not, there are 5 of every 10 people, this is 50% of people around us that are falling in the range of high or excessive bite force. It was very surprising at the beginning. However, it's not very surprising when you think of the amount of stress that people are living in nowadays. So be careful, because you may find people around you with excessive bite force. I personally found one of them in my living room. This is the bite force measurement for my wife. And I can assure you that many things have changed at home after I saw this number. So if you decide, if you have a team of 10 people and in your clinic or in your lab, and you decided to measure them, expect to see at least 4 to 6 people already on that range, like 950, 850, 900 and above. And with this very foundational information about bite force, what it is, what it's not, and before we move to the next chapter, which is going to be of this presentation, which is going to be the clinical cases and the clinical application of that, I would like to take that to the very first questions and answer section.
Wonderful. Thank you, Dr. Younis. It was very interesting. Glad to see that you're being mindful of the bite force of your wife now. Moving on, please, everyone, if you have any questions, now would be a time to either raise your hand or simply write them in the chat. So I do have 2 initial questions already for you, Omar. So I'm going to read them to you now. One of the participants was asking, does high bite force correlate to bruxism?
No, high bite force is not, I mean, high or excessive bite force doesn't necessarily correlate. There is no correlation or causation relationship between both. Patients with excessive bite force are usually, in many cases, patients, they have a kind of a strong muscle structure. They have strong muscles, but they don't necessarily suffer from any paraoral habit. It's usually related to the muscle structure of the patient rather than any other oral habit that can be related. No, they are not correlated, and there is no correlation between both whatsoever.
Very good. Second question. The question is essentially, why should you measure maximum bite force since we don't need that much to eat?
We don't need that much to eat. Yes, that's true. I mean, like usually majority of the food we eat is falling into the normal range of bite force. However, when we look at how patients exert that the forces, they are not necessarily just eating. Like you can see patients doing many other things. Another thing is when the patient starts eating, we usually measure bite force as an overall measurement, like across the arch, and also the right side, overall the right side, and overall the left side. Usually with eating, with biting on something, comes the stress concentration. And when this stress concentration happens, majority of bite force that the patient can exert are going to be concentrated in one certain area in order to bite on something. And that usually leads to more stress on this particular area. So I would say, assuming that there is a material like zirconia, for example, and we will show that in clinical cases, zirconia can have a compressive strength of like 1,000 megapascal. However, we have seen patients of excessive bite force breaking zirconia due to the low shear strength of zirconia, but at the same time, due to some sort of a concentration of stress at a certain area.
Very good. We do have another question. You're very popular. That's good. The other question is, I've seen patients that I know have an excessive occlusal force to the point of fracturing dental implants. When testing them, however, they score low. Do you think that they are able to exert more force during sleep?
I'd say that's one of the very interesting findings. Usually, assuming that a patient muscle structure is able to exert 1,200 newtons bite force, if this patient usually don't exert the total force, like the maximum force on their natural teeth, because there is the neural transmission, there is a neural feedback that's going to give the brain some sort of, you are biting too hard, you will probably break a tooth. So that usually is kind of a protective mechanism that's going to protect the natural teeth. However, when we put implant-supported restorations in the patient mouth, this neural feedback is now absent. Like it's not there, and it has been recorded in many articles that the patients are usually exerting higher bite force, like higher stresses on implant-supported restorations compared to what they compared to what they are to the stresses they are exerting on the sides that they don't have the implants on, that they are biting on natural teeth, simply because of this absence of that neural feedback.
We do have another question, and Dr. Younis, if I may also add a little bit to your last answer. The consensus in the literature about parafunction is also that whatever bite force we can apply during daytime, just like Dr. Younis was mentioning with proprioception, it can be 2 to 3 times that force at night. And you can imagine with implants, with the lack of proprioception, that could exacerbate the situation. Moving on to the next question. I'm going to try to make sense of what I'm reading here. Dr. Younis, eating force presses the food against the opposing dentition. Does the occlusal shape influence the loading on the opposing teeth?
No, the occlusal shape doesn't affect the loading against the opposing teeth. So if you think of it, the bite force is force exerted by the action of muscle, of the mastication muscle. And then this force is going to be transmitted through the occluding parts, which is going to be the upper arch, lower arch, and whatever in between, if there is anything that we are trying to chew in between or to bite in between. This force is going to be transmitted through these occluding components. So I would say the shape of the teeth is not going to affect the total bite force. The total bite force is the total bite force, the overall bite force. However, again, if there is a sort of imbalance in occlusion, like the teeth are not, the occlusion is not adjusted enough, or there are multiple high points So if the occlusion is not balanced, it's not built to be balanced occlusion, what's going to happen that this increases dramatically the risk of failure of the treatment and the risk of putting this patient in clinical danger.
Thank you very much. That is all for the questions for now. I think we can continue the presentation, Dr. Younis.
Okay, the next chapter is going to be jumping to the clinical application of that. And before we do that, allow me, Fred, to welcome one of the esteemed attendees. I never met him personally, but he may be surprised with the fact that I have coded some of his research work, Dr. Dennis Flangan. I never met him personally, but I have went through his. He's one of the pioneers in quantifying bite force in the and measuring the bite force influence on the success and failure of implantology and outside of implantology. Honestly, I never expected that he will be here, but that's a very beautiful surprise. Thanks, Dennis, for attending. That's really a privilege and an honor. Thank you very much. Okay, jumping to the next chapter, which is going to be the clinical applications. Before jumping in implantology, I would like to quickly go over this in everyday dentistry. What an everyday dentist, a GP dentist, how can they use the bite force? I would say the very first thing is going to be proactively the proactive diagnostics, and the second is going to be identifying the risk, which is also related to implantology, risk identification to minimize failure in the future, and obviously the restorative and prosthetic customization. A patient like that, when the patient shows up like this, that's probably too late. Like that's a patient that has lost a lot of vertical dimension and loss of that's a disaster. Like this needs a lot of work, and it's going to be a very long and costly treatment plan. The question is that possible to prevent? Is that something that we can avoid? And the answer is absolutely yes. So that proactive diagnostics is quite very important. I'm jumping through these cases to get to the implant side of things, and that's another application, which is like the identifying the risks, to identify the risk but not the crisis. Again, when the patient shows up with a broken or full arch, all on X, temporary restoration broken, there may be. It may be too late even to save not the prosthesis, but even the implant, if that happens in the provisionalization stage. And this kind of risk, and believe it or not, that's like you see this case, for example, which we will go through some of the details of these cases. You see, even with this big connector size, still the patient broke through this zirconia bridge. So it's quite important to pay attention to that. And I would say when it comes to implantology particularly, identifying the risk to minimize failure is pretty much the overall umbrella title that we can use. And that can be applied in across all the stages and across different applications, including the case selection and planning, the immediate loading, which is one very interesting topic that we will talk about, and the full arch rehabilitations as well. So when it comes to the case selection and planning, like think of in the pre-surgical planning, so we think of the implant angulation and how this angulation affects the stress, the overall stress distribution. Those who are doing implant planning, that's one of the cases that we have planned in DGRX. And the patient came in. It looks like, I mean, on the screen, it looks nice, but when we started planning the prosthesis, and then we printed the model with the provisional before we sent that to the doctor, we found out that the proclination of this anterior tooth is really high. And so what happened is we asked that doctor to measure the bite force for this patient. That was the very first thing that we needed to do. And because this patient was pretty much on the higher side, we ended up not immediately loading this implant for this patient. And according to research, this proclination or inclination is heavily affecting the stress distribution. So a 15 degrees angle would increase the buccal force component by 25 degrees. And if we increase the angle to 30 degrees, that's going to increase it to 50% increase in the stresses that applies to the buccal plate of bone. So even the slightest angulation, 10 degrees, 15 degrees, is going to dramatically affect the stress distribution and what kind of a stress is going to be applied for the prosthetic part of this implant, including the crown and the prosthetic screws, but also on the buccal plate of bone, which may lead to unfavorable outcomes in the future. And this is an ideal scenario in order to explain to the doctors why treatment planning, why pre-surgical treatment planning is important. And it's not necessarily because it's one single implant or it's a case of two implants. This is very important. It can be the planning, the pre-surgical planning can really be the difference between the success and failure. Another application of using bite force is the ability to select the implant size. Usually, most of us will be selecting the implant size just based on the availability of bone, which is absolutely accepted. However, I would say it may not be always possible. Like if you look at it's a lot of colors on the screen. I'm sorry for that. But if you look at the values here, it may not be really possible to put an implant which is 4.5 by 14 millimeter for a patient that's above 700 Newton per centimeter. The actual clinical application of that is to try to maximize the total surface area of osseointegration. So if a patient is having a heavy bite force, and now we were thinking maybe to put only two implants rather than three implants and three separate crowns, maybe we should advise that patient, hey, it's probably better for you rather than having an implant supported bridge is to have, if we have enough bone, obviously, is to have three implants rather than having only two implants. Also, for planning the all-on-X cases, it's in some cases you would probably want to go for all-on-6 cases, like more implant for this patient versus all-on-4 cases, for example, in order to increase the load distribution, the total surface area that the stress and the load is going to be distributed on. And one important thing also is the prosthetic design and how to customize the prosthetic design based on the bite force of the patient, based on your expectations of how heavy this patient is going to bite and how much force, how much load this patient is going to exert. In this case, we had a patient which is going to a patient for a bridge. And free and saddle, we're going to make a bridge, and this is the very first treatment. Like you can see here that the doctor tried to put a little bit of a cantilever, and despite the fact that many of us would say, "Oh, cantilever is doomed to fail," but we have seen patients living for life with cantilever over two implants supported like this, and it performed quite well. And that's one of the very famous cases where the bite force actually makes the difference. If the patient is really light forced, like if the patient bite force is really light, then cantilever, I wouldn't say we recommend doing cantilevers, but it will survive in this particular patient mouth for maybe for life. And obviously, as you may expect for this patient, because we didn't measure the bite force at the beginning, as you may expect, this patient came in with an overall fracture, not only on the cantilever side, but like obviously the ceramics, the zirconia got fractured in at the shoulder area. And what we did is we measured the bite force of the patient. Obviously, it turned out to be one of the high to excessive bite force, and we redesigned the prosthesis based on that fact. So if you look at the left side shows this the old broken restoration, which was designed to be two premolars and two molars. And if you look at the right side, this is the redesign. So it was redesigned to be kind of three molars and one molar. So it's a shorter span and obviously a shorter cantilever. And this is the follow-up of it just in August this year. Now that's another thing that can be applied in the which is going to be the prosthetic planning and the prosthetic designing. From my perspective, one of the most widely accepted and widely used in today's implantology is the immediate loading. And one of the most important uses of the bite force measurement device is going to be also in the immediate loading protocols. If you think of it, the whole industry is pretty much now deciding to load or not to load just based on one single factor, one single piece of information, which is going to be the insertion torque. Like what's the initial stability? The initial stability, which can be measured using the initial insertion torque. However, we have seen many implants that have been placed with great insertion torque, but they ended up failing. And probably most of the times they fail because of premature loading or because of the patient eating on top of them. And because of these patients are usually on high bite force. And here I'm coding and I'm quoting from the article that was published by Dr. Flangan, who is attending with us today for my pleasure, that the horizontal off-axial force of 150 newtons can displace a newly placed implant by 50 microns, which is potentially causing the integration failure. This is more than enough to cause the failure or to disrupt the process of osseointegration. And this is as low as 440 Newton, which can disrupt the osseointegration during immediate loading. So I would say if anyone, which I assume most of us has been doing that, if anyone is placing or deciding immediate loading or not immediate loading based on the insertion torque exclusively, that is making a decision based on like that's a one-eyed decision. There is another important factor, maybe as important as equally important to the insertion torque, which is going to be the expected load, the expected stress that's going to be applied to this implant after putting this prosthesis. I would assume that most of us, when we do immediate loading, we design the provisional restoration to be out of occlusion. However, out of occlusion means it's going to be out of occlusion in resting position, maybe in normal occlusion. However, once the patient starts eating, they will have to apply force on this side. And if the patient has a high excessive bite force, if the patient has high or excessive bite force, they are definitely, this is definitely going to be destructive for this immediate loading procedure. And that's going back to this case that I showed a couple of minutes ago about this patient, and the decision was actually made not to load this patient because this patient had a previous bone graft, and this was pretty much the last chance. It was a very tight area, very tight bone. It's in the anterior aesthetic zone, and the doctor decided to, after discussing with him, the doctor decided to play it safe and make it on like two-phase loading rather than immediately loaded, which obviously was against the requirement for the patient and the initial requirement of the patient and the doctor. However, it's pretty much important to let the patient know what are the risk factors and what can be happening and the possible circumstances of that. One important application also of the bite force in implant dentistry is going to be the predictability of full arch rehabilitations. Usually, when the patient comes to us and asks about full arch rehabilitation, we promise the patient something, But this, what we promise the patient is never numerically justified. So we promise the patient of, okay, this is going to be fixed. It's not removable. That can be possibly achieved easily. That's not going to be a problem. But the patient comes within, hey, you know what? Like I need to live normal life. And what normal life looks like. I want to get back to normal. Eat normally, eat what I used to eat in the past day before losing my teeth, and so on. And this is something that needs to be somehow quantifiable. And that takes us maybe to another slide that I showed about the what kind of bite force needed in order to chew or to eat different foods. Here, let's go with that example. This patient has a bilateral free and saddle upper and lower, and you can see because of that the patient bite force is heavily compromised, and you can see that that's less than 100 newtons. And obviously when she came in, everything starts with a good denture. So we created a nice removable denture, upper and lower, full extraction, upper and lower denture. And just by putting the denture in, you can see that the bite force now, when we measured it, it became like 179 newtons. And that's expected because now she has full set of teeth. It's artificial teeth, but she has full set of teeth. But one nice thing that we know for sure, that the maximum bite force the patient is able to exert on removable dentures is usually around 200, 250. Like 300 is going to be too much. Because above that line, like above the line of 200 newtons, usually it's going to start like causing pain and like mucosal pain during the pressure, and at the same time the denture starts moving in its place, so it doesn't really give the enough stability and enough fixation in order for these occluding parts to transfer this force that the muscles are exerting. And obviously, this patient came for Olum 4, so we did an Olum 4 implant treatment plan, and we applied 4 implants and then a supported bar and wraparound denture. And now you can see that it took the patient from a regular denture, a movable denture, from say 179 to 628. And there are many articles that says that even immediately after the treatment, you can see the dramatic improvement, but it keeps improving because as the patient starts chewing again and eating naturally again, their muscles gets conditioned and starts applying, getting back even like to 700 and 750, which is going to be within the normal range. So again, this is something important because it's related to what can we promise the patient? Can we promise the patient of taking them? Can we numerically tell my patient, hey, this is where you are at. This is the number. This is the bite force we're able to exert, and I can simply promise you to make this to normal, which is going to be this much. I will leave you with this quick video about this case, which is another case of Olum 4. That's the patient with dentures here, removable dentures, irregular removable dentures. Measuring the bite force with the removables, going to be 61 newtons. So you see how the patient looks healthy. He's not very old. Like he looks healthy. He looks quite young. Now with the implant supported. Insert. Measuring the bite again. Now you can see the total bite force of 541 newtons, which is pretty much back to close to the normal range. And again, it's pretty much proven that afterwards, once the patient starts chewing and eating normally, the bite force is going to be increased gradually till it gets back to the normal range. There is one final couple of final cases here that I want to show. I know that we are running out of time. I want to leave some time for Q's and A's. That's pretty much very similar to the concept of the cantilever, the distal extension. How far can you extend your prosthesis beyond the most distal implant in all on X cases? And again, that's something that we can just do it by and take our chances, or we can definitely have some sort of measurement, numerical justification for for that kind of extension. This is pretty much the final case, which is a very interesting case. So you can see that this case had pretty much an overall zirconia. That case was performed with all on 6 with overall zirconia restoration. Oh, and the zirconia restoration looks pretty well. I mean, it looks nice, looks robust on the X-ray. However, the patient came back. That was the outcome at the beginning. It looked nice. The soft tissue is okay. The zirconia looks fine. However, because of that length, the patient came in with a broken with a broken treatment. Like it came with a broken bridge. And even again, just like we said, even with this size of a connector, still the patient was able to was able to bite, and that heavily enough to break it. And obviously, what needed to be done is changing the material, which is the kind of material selection here, instead of using the type this type of zirconia. We changed it to a different type of zirconia, and obviously we also changed that to a different titanium basis, which had more support, and it turned out to be a successful treatment after all. And it came back for a recall visit this summer, and it was beautiful. And the patient is obviously quite happy with that. So again, just like we usually say, the difference between success and failure is not much. In implantology, we usually say, oh, you know what, it's 1 or 2 millimeter is enough to move the case from a successful case to a failed case. But I would say it's not only the geographic location, it's not only the measurements of where is the implant related to neighboring teeth. That's definitely important, but also there are many other aspects that needs to be measured. And I would say the mechanical aspect needs to be highly considered, which is pretty much the conclusion that we started the presentation with, that the patient individual bite force, it should be highly considered as an essential baseline diagnostic and risk assessment information in everyday dental practice. Thank you very much for attending. I really appreciate your time. If there is any questions before we conclude today's session, I will also leave my contact card, and it's going to be a pleasure and a privilege and an honor to stay connected with all of you. To you, Fred.
Thank you very much, Dr. Younis. I really highly appreciate the presentation. It was very insightful in terms of the content and what to prioritize in terms of mechanical components of restorations. let's jump to questions, everyone. If you have any questions, now would be the time to ask Dr. Younis. I do believe, did I see Dr. Flanagan's hand up for a question? Let me allow you to talk, Dr. Flanagan. Let's try that here. You might just have to unmute your microphone, bottom left of the screen, and we should hear you.
You can hear me now?
Yes, we can.
Oh, good.
We hear you.
That was a great job, Omar. It's really wonderful. Important information. I think this parameter is going to become more and more important as time goes on, especially with the advent of all-on-X goes along with our culture, practice culture. And we might find that there's a lot of failures in these cases when patients who have not been measured for this parameter.
I fully agree with that. It's usually most of clinicians and usually will fall into studying the factors related to the implant, but not all the factors related to the patient. So I would say the patient-related factors are not as heavily considered in the current day treatment plannings compared to the implant, the number of implant, the design of the implant, the threads, and all these aspects, which are very important. But I would say they should be more focused on the patient-related factors as well.
I published an article a few years ago, 6 years ago now, on predicting the feasibility of immediate loading on implants, full arches and otherwise. And as it turns out, only about 25 to 30% of the implants could be loaded immediately. Those are based on the bite force capability, the bone type, and the size of the implants that were there. So I'm starting another project now, very similar to this, at the University of Connecticut for this to embellish on this point. So I think this parameter is going to become a very important thing to measure preoperatively. I mean, even when you're talking about conventional fixed bridges between two teeth, that might be an important parameter to know how much load that you're going to impart on your bridge.
I would fully agree. Thank you very much, Dr. Flanagan. I am personally looking forward to that new publications to embellish the previous one. I'm very curious about potential thresholds in terms of force to determine if immediate loading is suitable or not, because a lot of clinicians are asking us that question. What kind of bite force is the threshold to go immediate loading or not?
Yes. I'm collecting data now to start get a baseline on occlusal bite loading. We're in the process of collecting data right now, so
that sounds
that would be beautiful. And again, I would like to thank you, Dr. Flanagan, on for attending today. I didn't expect that. Like as you see, I had your name coded in my presentation for the great research that I have went through, for the great research work that you have done throughout the years. And having you attending the presentation today is a real privilege and honor. Thank you very much.
Well, thank you. You did a great job. It's very important information that you're conveying.
Thank you. Appreciate it.
Thanks, Dr. Flanagan. We do have another question here. Someone is asking, do you recommend Botox for high bite force?
That's a great question, and I would say it's definitely one of the lines of treatment. It's one of the suggested lines of treatments. I would say it depends much on which school you would want to use treating your patient. Many of the clinicians would start with some sort of a non-invasive dental treatment, just putting maybe a night guard. If there is any loss of vertical dimension or any kind of occlusal reason for this kind of excessive bite force of the patient that's triggering the patient to bite quite hard. And I'm not talking about paraoral habits. I'm talking about the excessive bite force. I would say most of the dentists would start with non-invasive way of treating that or decreasing that by using some of the flexible or like kind of rubbery night guards or bite guards. And it has been reported that the clinics who are using the Enobite are prescribing way higher amount of night guards and bite guards, because just like we said, the prevalence of the prevalence of high to excessive bite force in patients is pretty much around 50%. However, in some cases, you will have to go a little bit invasive, and you will have to you may need to use Botox in that. Yes, and that's one of the valid lines of treatment. You are absolutely correct.
Very good. We do have one more questions. Again, if anyone has any more questions at this point, now would be the time. The last question is, Dr. Younis, what is the maximum force to include a cantilever in the prosthetic design?
That's a great question, but I would say if any patient is on the higher side of bite force, like if any patient is like above 750, I wouldn't go cantilever for these patients, because that's going to be quite dangerous. Obviously, shorter cantilevers with multiple implants splinted together is going to be way more secured. But I would say for a patient to be cantilevered kind of safely, they should be on the lower side of normal. Like I would say maybe 600s, something like that. That would be obviously more research to be done on that, but we don't want to forget as well that there are many factors related to the cantilever. Not all cantilevers are created equally. Like, I mean, is this cantilever on one implant, two implants? What's the distance between these two implants? What the extension of the cantilever itself? Like what's kind of in millimeters? Or the cantilever area, this undermined cantilever area, how long is it? There is some mechanical theories related to the beam length and how far cantilever can be, how long cantilever arm can be versus the length of the implant. But I would say any patient above 750 is not really recommended for cantilever. Like I would avoid cantilever in these patients at all costs.
Very well. Again, I do believe this was our last question. If anyone wants to raise their hand or ask one last question, now would be the time. In the interim, Dr. Younis, I do want to thank you for this really great lecture. It was very insightful. For everyone that attended, a little bit of housekeeping now. Once again, we will be sending the C certificate to each and every one of you through email in the coming week. And if you do have any other questions for either myself or Dr. Younis, please feel free to reach out to us. We'll be happy to put you in contact with him to discuss further the topic of tonight. We want to thank you for your time. I know for some of you, it's a little later in
It's
Canada.
quite late. Yeah,
Yes.
I really appreciate it. It's quite late for many of the attendees. Yeah, I know.
And for the one on the West Coast, it's a little bit less late. It's probably dinner time about now. So if there's no more question, I think we're gonna conclude the lecture. Once again, Dr. Younis, a big thank you from us.
Thank you very much. Thanks,
And
Fred. Thanks for the invitation.
we will wish everyone a wonderful evening.
Thank you.
Thank you very much.
Bye.
Good night.
Thank you.